Good morning. Well, I came back. I'm not sure how many of you were here when we were here in November, but we went through all of this material. There were lots and lots of questions that were submitted, and so really our focus over these 2 days is that we are going through this material to refresh, to answer as many of the questions as we can, and address them as we come to the slides that relate to those, and to provide any further guidance and assistance that we can now that you've had 2.5 months to start working day to day with OASIS D. Because it isn't until you actually start working, using it and applying it to patient situations that it gets very real. And I know that the questions you may have over the next 2 days are going to be different from the questions you might have had in November, now that you're actively using this in patient care. So first thing this morning, we're going to start by looking at that overview of the OASIS changes again. The first few slides are our dictionary of all the acronyms that we'll be using in this presentation. And we're not going to take the time this morning to go through those because you're familiar with them and you know now where you can find them should you need them. And I will tell you that I definitely used that list of acronyms because we all become so tunnel focused on our piece of this arena that I had to stop and think, wait, IRF, what's that again? And I went back and looked, that's right. But we do need to expand our view and become familiar with all of those terms and who each part of the continuum might be. So as I said, our objectives this morning for my piece of this is to first begin by looking back at the IMPACT Act and reminding ourselves of what the goals were for this very important piece of legislation. We're going to go back and revisit the relationship between the data that you're collecting in the OASIS and the goals that were spread out in the IMPACT Act. And we're going to describe the changes yet again to look at what we're doing differently in OASIS D from what we did in OASIS C2. So the IMPACT Act, it's 5 years old now, from October 6th of 2014. This act required us, as part of the post-acute care providers continuum, to report standardized patient data and quality measure data so that we were actually speaking the same language. So that when you take a referral from any other point in the continuum and someone addresses that patient's functional ability, we are all using the same yardsticks. The post-acute care arena affects long-term care, inpatient rehab, home health, and nursing homes. And on this slide, you have a good summary of each of those different arenas, the cost, the number of the providers. I absolutely was floored looking at these numbers, and the totals. So why does this matter? And why did we get started doing this in the first place? If you have spent any time looking at the history of how healthcare evolved, originally, our piece of this continuum came about because when insurance, primarily Medicare, made hospital stays more affordable because people didn't have to pay it out of their own pocket directly, the cost of healthcare went up as people accessed hospitals. And this should sound familiar. Suddenly there was much hand-wringing and we must cut these costs. Let's send them all home. So they carved out a piece of the Medicare money for hospital stays and created us. So now we get reimbursed. That was nice. Our reimbursement was not a big piece of the pie. And as more and more people used it, and there are more and more of us in this room, the cost went up. And so now we are looking at all of the costs across the arena of post-acute care to see where we can control cost without compromising patient care. We need to be sure that we are using data that goes across the continuum to coordinate the care so that we don't duplicate. That drives up the cost and does not improve the outcomes for our patients. And improving the outcomes for our patients, measuring those outcomes, improving the quality of, it says hospital discharge planning, but really we're looking at the transition. Regardless of which point they came from and went to, we really all need the same language and the same measures in order for us to accurately control and facilitate the quality of care. So that's why there's so much attention on post-acute care. I've talked about standardization. What exactly does that mean? We're standardizing our functional assessments at the item level, at the task or ability level. Having data that is standardized and meaningful across the continuum would be like hitting the jackpot. Except if I put my 50 cents in the slot machine and I got this, I didn't win a thing. I lost my money. And those are our tax dollars. We need to be sure that we have meaningful, standardized data so that we are all speaking the same language. Then, when we put our money in, we will hit the jackpot of data. We'll be able to look at progress across the continuum. We will all speak the same language. When that happens, because obviously as each of the settings is so different, you really can't compare walking a specified distance in the hospital setting, in the long-term care, skilled nursing facility setting, and the hallway of an apartment building. There's a difference. So yes, there will always be some differences. Each of the spheres will have its own color setting and its own uniqueness. But the white area in the middle, that's our standardized patient assessment data elements, the SPADES. And when they all line up, we absolutely have a jackpot of meaningful data across the continuum. There is a video on the CMS YouTube channel, which is an absolute goldmine. I speak to providers every single day, and I'm directing them here because you can use this as a resource for training your staff. Today's presentations are all being recorded. They're being added to the ones that are already up there. And this one is there so that you can get an overview of the IMPACT Act for yourself, for all of your clinical managers, so that you will understand and become more and more committed to the mission of what we are doing. Part of our goal today is to really understand the changes that were effective 2.5 months ago on January 1st of 2019. There were significant changes made. 6 new items were added to the tool. 7 items were revised, either in the wording or where they were. 28 were removed specifically to reduce the burden on providers. 33 things were changed in the manual. This is a list of the M numbers. This is an area where if you shared this slide with 33 changes in the guidance manual and you put that up and said to your staff, now you all need to go look in the manual, you need to read this, you need to understand this, they're all out the door, right? But as quality managers, clinical managers, administrators, this is your job. You need to go back to your manual if you haven't already, and I'm not asking for a show of hands. When I sat in your chair, pulling out the manual and looking at 33 wording changes or corrections was not high on my list. I had nurses to meet with patients to get care set up for. But you do need to do this because it's on us to make sure that the nurses understand the changes that were made in the guidance that will affect them. OASIS was changed from C2 to D for 4 reasons. The IMPACT Act required the standardization, and we've talked about how critically important that is. Cross-setting alignment, we've talked about that, and how important it is that we are all speaking the same language. When we say that the patient can safely arise from the sitting position and stand and then walk across the room, do we all mean the same thing? Do we all assess it the same way? That's cross-setting alignment. We needed to look at reducing the paperwork burden. We all know doing a full, proper OASIS assessment in the home can take upwards of 2 hours. And if your average patient is 80 years old, they aren't making it for 2 hours of show me how you do this and show me how you do that. So we needed to really reduce the burden, not just in paper, but on our staff and on our patients as well. We also needed to be sure that with the new conditions of participation that we spent last year trying to get used to, that the measures and the language are coordinated with anything that changed in terms of survey and certification. And as we go through, we are going to see that there are places where I can point out to you that this is directly matching up with survey and certification requirements. And lastly, we did have to make those general updates and corrections to be sure that everything in the manual, everything in the tool was consistent across the board with the most current terminology and definitions. As I said earlier, we did add new items. And Charlotte is going to go over with you in detail Section J on health conditions and the falls data, and Section GG. Okay, now I see everybody going, GG is a scary thing. When we looked at those questions the first time last year, I remember everybody going, oh my God, we're never going to get the nurses to do this. But they're doing it, aren't they? They're not crazy about it. I know, I hear that. You should see the looks I get when I go out to teach a room full of nurses about GG. But we do need to understand this and understand it clearly so that we can teach it. And Charlotte's going to work with you on that so that when you leave here tomorrow, you will feel like you've mastered this and you can take this back and teach this. This slide is going to take you through these new items and when their time points are so that you'll know when and where to expect them. The revised items include the active diagnoses, M1028, the unhealed pressure ulcer or injury at stage 2 or higher, the current number of unhealed pressure ulcers at each stage, the current number of stage 1 pressure injuries, staging the most problematic unhealed pressure ulcer or injury that is stageable, and then the last two, we're going to talk in detail about those shortly, the types and sources of assistance and the reason for emergent care. 28 items were identified to be removed to alleviate the data collection and the data burden. The ones that were removed were specifically because they did not support one of these specific areas. We didn't need them for the quality reporting program measures. We didn't need them for prospective payment. They did not relate back to the survey process for your Medicare certification. They did not need to be collected or measured for value-based purchasing demonstration measures. They were not a critical risk adjustment factor, and they did not tie back to the conditions of participation. These next few slides are going to give you an overview of each of the items, and they're going to show you the time points that were affected. But again, this is something that you can go back and look at specifically to answer your own questions. And I don't want to put everyone back to sleep, although if you had a late flight last night, you might need a little nap, but we're not going to go through these in great detail. I do want to call your attention to these four. These 4 were removed from the discharge element only. So that you do want to look closely at that. They are still being collected at SOC, ROC, and follow-up, but they have been removed from the discharge time point. Now these 2, I said to you earlier, we're going to be looking at these in a bit more detail. Each of these 2 items had a long list that you were selecting from when you were collecting data for these 2. The types and sources of assistance that your patient required to be safe in the home, and the reasons for emergent care. Now, in both of these items, elements for your selection have been removed because they were not critical for data collection. They were not critical for the purposes of the OASIS D. But for those of us in this business, they may very well have been critical data elements you were collecting to inform your quality management programs, your performance improvement projects. So what this is doing is it is asking you to now go back to your agency and say, if I needed these elements, how am I going to continue to collect them? And I would suggest that you look to your EMR vendors and see if there is a way for you to continue to get this data if you need it. I know the providers I work directly with have found that this was something they needed to do. They have worked with their vendors to continue to collect this information to inform their performance improvement projects so that they could zero in on what they were doing. The items that were removed, we all know about the skip patterns. Remember when OASIS first came out and it was a paper tool and all the errors that were occurring because there were skip patterns. And people would answer the question, they would zip right along and not see if you answered this, skip to the next, and they would just answer everything. And that invariably messed up the data and had caused us to be looking and making corrections for hours. The electronic medical record systems have helped us with that. If, for some reason, you are still on paper, you're going to need to look carefully at this list, hang on to it, because these elements are affecting the skip patterns. Let's take a little deeper dive into the items that have been revised. Our goal for this section is to identify the assessment items that have been revised in the OASIS D and to summarize the changes for each of those revised items so that you can make a plan. And we can talk more about that at the end. Hopefully, I will have carved out a few minutes for you for action plans so that you're taking today's information, thinking about what you're seeing in the last 10 weeks of your nursing staff, your therapy staff, collecting OASIS D data so that you can create an action plan to address those bumps in the road that you're having with implementing this tool. The OASIS D changes involve one of 2 things. Either we have changes to assessment items and the related guidance for those items, or we have, as I said before, a large chunk that is revisions that were made to the guidance manual only. The 7 items that were revised, we ran through this list before. Now we're going to take another look at them, at what was revised and why. And I do want you to pay attention to this and think about, are you having a problem in your agency, with your staff, as you review the OASIS that are submitted? Are you seeing an issue in any one particular area? Because if you are, this is a place for an action plan, a performance improvement action plan that you can implement when you go back to make sure your data is 100% correct. The revised items may have changes in one or more of these areas. It could be the time point that they're at and the version of the tool that you're using. It could be the exact wording, and we're going to look at the ones that have had wording changes. Could be the response options Remember types and sources of assistance and the reasons for emergent care. That's a place where we made significant changes in the response options. The use of the dash was new to all of us. And I remember when we first started working with this and talking about the dash, everyone saying, well, where am I going to put it? It's not an option in my OASIS. When I go back and look at my EMR, it's not there. Well, they put it in there for us, and we're working with our nurses, aren't we, to get them to understand you do need to get as much information as you can. The dash is not a cop-out. That's why CMS wants us to remember over and over, this is an item to be used rarely. And lastly, those skip patterns have been changed in many areas. You have those 33 guidance manual changes. You do need to go through them to be sure that you understand which ones might have to inform nursing and therapy practice when they are doing the assessments. For those 33 items, they have been updated in one or more of these 5 areas that are in the manual for each and every assessment item. The intent, why am I asking this question? Time points collected, when do I have to do this again? The specific instruction for how to interpret the responses and how to answer the question. The examples given so that you and your staff can better understand how to apply the query. And then the data sources that you can use to get the information that you need. These include response-specific instructions on the one clinician rule being expanded to allow collaboration. This is so critically important. That expansion of the one clinician rule ties back directly to the conditions of participation and the concept of a multidisciplinary team creating a multidisciplinary integrated plan of care. That's how the OASIS-D ties back to survey and certification, is the expansion of the one clinician rule. In the guidance manual, you want to look at what content was associated with the items that have been removed. The skip language has been revised. That's the instructions to you and your clinicians. And over, there are places where it points out the alignment with the new conditions of participation. Neither one of these changes was done, as large as they are. None of them were done in isolation. They are integrated. I know that when we're in the trenches, it just doesn't feel that way, does it? It feels like somebody dumped a big manual with the new conditions of participation on one side of your desk and dumped the OASIS-D manual on the other side, and you're stuck in the middle. But these two things do talk to each other, and they do tie together, so that you do want to look at this to see where they are linked and how that can help you. And we've aligned the language that we use across all the post-acute care settings, so that just as that earlier slide showed you, you can finally hit the data jackpot. You can finally understand what that discharge planner was talking about when she uses the terminology she does, because now we'll all be using similar language. In the guidance manual, there are references to specific CDC and prevention content material, and now there's a general statement referring you to the CDC. Additional definitions were added. Some references to quality measures have been removed because we are no longer collecting those measures to reduce your burden. And then there were some minor editorial changes made. Okay, so now that I've gotten this far, it's time for me to find out if everybody's awake or if you've all mastered the art we had in college of that glazed look, the one where I'm really thinking about something else, but I look like I'm listening. Get out your phones. If you remember how Bridget explained to you to use the Slido, we're going to ask the revisions to OASIS-D involve which of the following? Changes to assessment items and related guidance, general revisions to the OASIS-D guidance manual, or both A and B. Oh my goodness, look at that. We have 100% on A and B. Let's go back and see if you are correct. Oh, can we return? There we are. Now let's see. And A and B together is the correct answer. The reason behind it was that we did go over, there were changes to 7 assessment items and much of the related guidance, and there were general revisions in the manual to intent, time point, response-specific instructions, coding examples, and data sources and resources. Okay, let's move on. We're going to talk about some of these item-specific changes. Again, here's our list of the 7 revised items. M1028. I remember when we first brought this measure out, a whole large room full of people were going, well, yes, but what if nobody has, what if they don't have either one of the first 2? And I said, well, you just wouldn't check anything. Well, how am I going to know the nurse didn't just skip it? That's why this has been changed. The response option was revised to align with the other post-acute instruments, but also to improve the quality of the data. An option 3, none of the above, was added, so that this is how the item looks now, with option 3, none of the above. So that now we have quality control on this item, and your clinicians need to know whether the patient has peripheral vascular disease, diabetes, or none of the above. With the unhealed pressure ulcer injury at stage 2 or higher, M1306, we've incorporated the terminology updates so that we are now in full alignment with the other post-acute care instruments. The text was revised to have the statement includes healed stage 2 pressure ulcers, changed to excludes all healed pressure ulcers injuries, and added the words injury or injuries. This is how it looks on your OASIS tool. You want to pay close attention to the areas that were highlighted here on the slides and go back and look at the tool itself in your electronic record or your paper version. Similar changes were made in M1311. We incorporated the terminology updates, we modified the skip pattern language and the directions, and the item was retained, but different versions were created for SOC-ROC follow-up and discharge. This information that you gather at SOC-ROC and discharge is being used to calculate the revised pressure ulcer measure. A dash is a valid response at the discharge time point only. And as we will say in each one of these changes, it is expected that the use of the dash will be a rare occurrence, and this was done to standardize this IMPACT Act measure. In 1311, the text was revised. They've added ulcers injuries wherever it was applicable. And take a good look at item D1. The word device was added, referring to unstageable, non-removable dressing or device. And the phrase was removed, suspected in evolution, from F1, unstageable deep tissue injury. Oh, come on now, move along. There we go. Every once in a while, the clicker decides to go into rebellion. This is how the item looks on your screen when your staff are using your EMR or in a paper tool. Again, the yellow highlighted items are the places where the changes were made. This is the discharge version. Again, you'll see the same highlighted elements where changes have been made. 1311, in the discharge version, again, you see where changes have been made. I know those slides of the queries are very small, and so we're not going to spend a lot of time on them because it's much easier for you to go into your own electronic record and pull one up. so that you can enlarge it and actually take a look at it. In 1322, this item was retained at sock, rock, and follow-up, but removed from the discharge time point because it was not needed for the measure calculation. This is to reduce the burden of data collection. It aligns better now with other post-acute settings because we've replaced the word ulcers with the word injuries, bringing us to current terminology, and updated the stage 1 definition for the same reason. Here you see 1322. It's completed only at sock, rock, and follow-up, as I said before, and you can see the terminology changes have been highlighted here for you. 1324 had some language updates to add the word injury. And here you see 1324, sock, rock, follow-up, and discharge. This one remains at all of those time points. Let's take a look at 2102, the types and sources of assistance. Remember, we talked about this earlier, that what they've done here is they've removed several of the options so that we are only collecting the data that is critical to the measure. But we know, we understand that you may well have been using that other responses for quality management purposes. So you will need to look at whether you still need it and how you're going to go about continuing to gather that information. The changes that were made to this item are that there will be different versions seen at sock, rock, and at discharge. And the options that were deemed not essential to the measure were removed to decrease your burden. Here you can see the response items that were removed, and the only response item that was retained is supervision and safety. But they did keep the lettering option so that the F is still there. What that will do is it will facilitate for you if you need to use this in some way for your personal agency data collection. You can then go about working with your vendor to continue to collect that information. So that here you see the way the item looks on the screen now when you do OASIS D. At discharge, they removed 3 items and retained 4 for types and sources of assistance, so that you see that there is a difference now between the previous and here. This is what it will look like on your screen. And again, they retained the lettering sequence for the same reason as they did in the others. Now let's look at emergent care. This is a situation where I will admit freely, when this first came out and we first began studying and preparing to teach this, I looked at what was removed for reasons for emergent care, and all I could think of was, oh my Lord, how are the providers ever going to continue to get the data they need for focused improvement plans? And so you're going to have to look at how much of that you need on an ongoing basis and how else you can collect it, because the goal was to reduce your burden and only require you to collect that which was needed for the measure. So M2310 is completed on transfer and discharge. The response options that were needed to calculate the measure were retained, and the remaining 15 of the 19 were not needed for measure calculation and were removed. These are the 4 that were retained. If you've looked at the reasons for readmission, you'll remember that medication errors and problems were one of the #1 reasons for readmissions and emergent care. So that had to be retained. And diabetes was very high up there, and that left us with the other 2. This is how it looks now. So let's see if we understand what we've talked about. Get your cell phones out and go to the Slido. Which statement regarding the M1028 active diagnosis is true. New time point versions have been created. Response options have been revised to include none of the above, and the dash is not a valid response. Oh, not bad. No, people are changing their minds. Got a little waffling going on here. Okay, changing again. All right, now, pick an answer, troops. Let's, okay. Which statement regarding the M1028 active diagnosis is true? The response options have been revised to include none of the above. And that was added as a new one so that we could maintain better quality control. Here's the next question. The same assessment version of M1311 is used for sock rock, follow-up, and discharge. Is it true or false? Let's mark it on your phones. Let's see how we do here. Oh, look at that. No, now enough, don't change your minds. Remember, your first answer is usually right. Okay, let's go back and take a look. And the correct answer is false. M1311 has been retained, but the versions are different between sock rock, follow-up, and discharge. And only sock rock and discharge will be used to calculate the revised measure. One more question. Select the best response for M2102, types and sources of assistance. Is it A, response options have been removed to reduce your burden? New time point versions were created for sock, rock, and discharge. Retained the lettering sequence for response options, or all of the above? Well, there we go. Remember, your first choice is usually the right one. Let's go back and see how we did. And the answer is all of the above. We're doing really well here. The correct answer has been well up in the 90s. We did remove some of the response options to reduce your burden, and there are new versions for sock, rock, and discharge. Let's look at some additional clarifications. The one clinician convention we talked about in great detail. This was modified on January 1st of 2018. It is still the responsibility of the assessing clinician to accurately complete and sign the comprehensive assessment. But he or she may collaborate with other peer professionals to collect the data for all the OASIS items if your agency policy allows. That's 3 very important words. If your policy allows. You need to go back to your policy manual for these items and make sure that you've addressed them. There are modifications in the guidance regarding the One Clinician Convention. This was done based on feedback from provider stakeholders and to better align with the assessment practices across the other settings. Any exception to this is going to be identified in the item-specific guidance. Take a look at the picture here on the slide. We have a group. And we know that this is what is expected of us in complying with the conditions of participation, that we have interdisciplinary collaboration. It's a critical issue. There's additional information here at this link on the One Clinician Convention. There were no changes made in drug regimen review for home health. The big change is that drug regimen review was now implemented in the other 3 settings in 2018. So it was brand new to them, and they have struggled with that as we have struggled with other items. Now, the drug regimen review quality measure is uniform across all of the settings. Height and weight. There's been so much discussion about this, and there were so many questions that came in that I really need us to think seriously and carefully about this. And as we go through it, I want you to hold one thought that is going to make this much easier to understand. When your patient has a chronic illness or an illness that requires us to monitor weight and fluid balance, it's not the actual number so much that matters. It's the plus and minus that matters. How do we know if your patient's slipping into failure? The fluids come up, their weight goes up. Their weight is going to be radically different from scale to scale. That's why it says a consistent scale, consistent location, consistent timing, because it's not so much about the number as the changes in the number up and down. So this query is completed at Sock and Rock, and we are collecting the patient's height in inches and their weight in pounds using the traditional rounding system. You need to define when and how and where and why this is done in your agency's policies, because your staff needs the structure and the guidance. Because if you don't give them that, you're going to get reports that were as reported by the patient, as reported by the family, from the W-10 referral information, none of which is acceptable. If we're weighing the patient multiple times during that 0 to 5 day assessment period, you need to use the first one. Because again, what is it that we're looking at? The up and down. We need to only use a weight that's been directly measured by agency staff, not one that is information gathered from another source. Whenever it's possible, we need this information as part of the start and resumption of care assessment. If it is absolutely not possible for you to weigh this person, they are completely bedbound, they are in severe pain, they have a very high risk of pathological fractures. Those are valid reasons for you not to be able to directly weigh this patient. Almost no one has a bed scale in their home. So you do need to have a way to accommodate this, and that's when you're going to be able to use the DASH. So I know this appeared in the Q&A, and I do want you to hold on to that explanation, because that's how you should teach it to your staff. That's how you need to monitor it for quality assurance. Let's get out the phones. We're going to take a look at the one clinician convention and see if we remember the correct answer. The comprehensive assessment, which includes OASIS, is the responsibility of one clinician. The assessing clinician may elicit feedback or collaboration from other agency staff to complete the OASIS. Or is it A and B? No, there we go. Let's stop here and take a look at the answer. And the answer is both A and B. There we go. And we know that this is correct because we are pursuing a goal of collaboration to be sure that we have all the correct information. Let's take a quick look at what we remember about height and weight. Are we entering a weight that we obtained from the patient's spouse? A documented weight from the skilled facility discharge summary? Or a documented agency weight obtained within the last 30 days? Can we use an estimated weight from what the patient tells us? For the first time, we are unanimous on this, and I think it's because it's been a burr under everybody's saddle. Let's go back and confirm that, yes, indeed, we were correct about that. The slides got away from me here. We can only enter a weight that has been directly measured by your staff, and we can document. If there was no way we could do it here, if we had one from the agency staff in the previous 30 days, you can use that. OASIS D should be used with all the assessments you do from January 1st of this year forward. We have new assessment data elements, we have revised elements, we've removed some elements, and we've updated your guidance manual. So now, we're down to the end, and we were very tight for time. So I really don't have any spare minutes to enable you to give me some action plan ideas now, but please save them, because this afternoon we're going to be doing an actual action plan based on some sample reports. And at that time, we can also look at any other action plans you may have. And we'll be circulating around later. If you have questions, please feel free to come on up and ask. That's what we're here for. Thank you.